All right. So let's go over a week 5 quiz review. So we would have covered chapters 27 through 29 and then 31 and 33. So like kidney diseases and renal diseases as well as some reproductive diseases, right? So looking at chapter 27, right, we looked at some diseases, and so definitely focus on the highlights, focus on everything in the PowerPoint, right? Try to definitely condense everything down. So when we look at acute pyelonephritis, right, we're looking at an infection of the renal pelvis and the kidney tubules. So you have to understand, number one, well, what is acute pyelonephritis? Again, it's, an infection of the renal pelvis and the kidney tubules. Usually, it's going to be caused by an ascending urinary tract infection. Now, the most common cause is going to be E. coli, right? So E. coli is going to be the most common cause of this acute pyelonephritis, right? It can also lead to urinary retention and reflux, okay? So, that fluid is ascending in the opposite direction, going back from, the urethra, the bladder, the ureter, back up into that renal pelvis area and the kidney tubules, thus leading to the infection, right? So you also want to understand, well, what are some clinical manifestations of acute pyelonephritis, right? Costal vertebral angle tenderness, some chills, some vomiting, right? Also fever. You're going to see fever with a lot of these disorders, right? But you got to remember that that's going to be one of the clinical manifestations. I also put this terminology there as well, nephralgia. And so that's simply just pain associated with, kidney disorders, okay? So you want to remember that as well. Excuse me. Oh, now we're having a coughing contest, sorry. So we also want to look at nephrolithiasis, right, or these renal calculi, these stones basically. So these are stones that are going to form in the urinary tract under the conditions when we have too much solutes, so like solute saturation, low urine volume, abnormal urine pH, and even dehydration, right? So if you're not bringing in fluids, or if you're dehydrated, if you don't have that much fluids in your body, then these solutes will become supersaturated, or they can become supersaturated. So that can be a cause of these stones, right? So you got to remember that. Now, most stones are going to be composed of calcium crystals, right? So calcium oxalate. So that's number one. Most stones are going to be composed of calcium, right? And what will facilitate these calcium stones to be formed? Hypercalciuria, right? So too much calcium basically in the blood, too much calcium in that urine, okay? Also, what you got to remember is stones that are composed of uric acid are going to be associated with gouty arthritis, right? So if I ask, well, what stones are going to be associated with gouty arthritis? It's going to be those stones really composed of uric acid, okay? Another thing that we have to remember, so some of those stones that are going to be caused by urea splitting bacteria, those are going to be those struvite kidney stones, right? So you got to remember that as well. Those struvite kidney stones, they're going to be caused by urea splitting bacteria, okay? And when we look at hydronephrosis, so what is hydronephrosis? Hydronephrosis is where we have a blockage or an obstruction of the ureter, resulting in like an enlargement of the kidney. Okay, so you have to remember that as well. And whenever we look at these stones, right, patients with these stones, they're typically going to feel pain, right? They're going to feel that pain, right? And that's going to be like that nephralgia that we just talked about, that we just mentioned. And so we have intrinsic pain coming from within, like the kidneys or the tubules, right, the glomerulus. And then we have extrinsic pain. So extrinsic renal pain or extrinsic renal obstruction, that could be due to like a pelvic tumor, okay? So you want to remember all of these aspects, okay? When we look at glomerular disorders, excuse me, glomerulopathies, right? And so we have glomerulonephritis. So glomerulonephritis is where we have an infection or inflammation of the glomerulus, right, of the kidneys. And so right here is going to be the glomerulus apparatus within that Bowman's capsule, right, of the renal corpuscle. So we have acute glomerulonephritis, right? And you got to remember, so this is like an autoimmune reaction. This is an immune complex reaction that's going to involve IgA antibody, okay? And so the clinical manifestation of this is where that patient is going to have proteinuria, right? So proteinuria is going to be consistent with diagnosis of glomerulonephritis. Gotta remember that, right? And so essentially, because of that, glomerulus is inflamed. Now, typically, ideally, normally, you should not really filter, proteins, right? They're just simply too large. That basement membrane is negatively charged, so it will repel those negatively charged proteins as well. However, when that glomerulus is inflamed, right, under certain conditions like glomerulonephritis, acute or chronic, you're going to find proteins that's going to get passed through and that filtrate, and then you're going to find that in your urine. So that's why proteinuria is going to be a constant diagnosis with glomerulonephritis. Okay. And again, chronic glomerulonephritis is just an extension that we see in acute glomerulonephritis, right? Now, when we look at crescentic glomerulonephritis, we used to call it rapidly, or we will call it rapidly progressive glomerulonephritis. And so what characteristic you need to understand about this is, number one, there is a swift decline in renal function that progresses to acute renal injury. And most common infections, right, will be, post-streptococcal infections, right? So meaning if a person has strep throat, it can then lead to this crescentic glomerulonephritis, okay? When we look at nephrotic syndrome, this is simply, so understand what this is. This is a loss of large amounts of protein in the urine due to the glomerular leakiness, right? And so this loss of large amounts of proteins, right, that's obviously will lead to proteinuria, and it's then going to be associated with hypoalbuminemia, right? Meaning you don't have that much albumin in the blood because you would have lost it in your urine, right? So remember the function of albumin, right? The most abundant plasma protein. Yes, it's the smallest in size, but it really is important for that oncotic pressure, or that osmotic pressure. That osmotic pressure is a pulling force, pulling that fluid back into the blood vessel. And if you lose that pulling force, that fluid will leak out of the blood vessel and it will lead to generalized edema, right? So you got to remember that about nephrotic syndrome, okay? Also, when we have hypoalbuminemia, that's going to stimulate hepatic synthesis, and that will also result in hyperlipidemia, okay? So when we look at chapter 28, acute kidney injury and chronic kidney disease, right? So when we look at acute kidney injury, we have pre-renal kidney injury, post-renal, and then intrinsic intrarenal kidney injury. And I want to focus on intrinsic intrarenal kidney injury. And so we have tubular or acute tubular necrosis, and that can be caused by, ischemia, right? It could also be caused by nephrotoxic agents as well. Okay, so you got to remember what are the causes of acute tubular necrosis, right? When we look at chronic kidney diseases, right? Well, what's the risk factor for chronic kidney disease? Hypertension, and diabetes, right? These are the most common causes of chronic kidney disease, but you got to remember that, okay? And so what happens with the progression of chronic kidney disease is we have a decline in our renal function that is typically going to be progressive and irreversible, right? We'll also have uremia that will develop, and that's going to have like urea in the blood, right? And that's simply because your nephrons are progressively deteriorating because your GFR, your glomerular filtration rate, is declining, right? So this is a progressive type of situation, okay? One of the best ways to get an accurate reflection of your renal function is going to be your serum creatinine, right? You're taking blood, right? And seeing how much serum creatinine will give you, an accurate representation of your renal function, the health of your kidneys, basically. So if we have a decrease in glomerular filtration rate, we're going to have an increase in serum creatinine, right? So that creatinine is going to be able to remain in the blood, okay? And this will tell us about the health and the function of our kidneys. Excuse me. So you got to remember the complications of kidney disease, right? A couple of questions will come from that, right? Number one, hypertension and cardiovascular disease, right? You'll see uremia. and that's because you can't excrete urea. Now, when we look at metabolic acidosis, it's going to lead to metabolic acidosis because you will have an insufficient metabolic acid excretion out of the body, and that's really going to be, again, because of a loss of nephrons over time, okay, which will lead to those acids remaining, okay. When we look at an electrolyte imbalance, right, so the most immediate life-threatening complication from these electrolyte imbalances would be hyperkalemia, okay, would be hyperkalemia. So other complications, right? So mineral and bone disorders. So remember, osteoporosis will be also seen with end-stage renal disease, and that's really going to be due to hyperparathyroidism. Okay, literally taking that calcium out of the bone and putting it into the blood. Malnutrition also will be a complication of chronic kidney disease, as well as anemia, right? So anemia will be a complication. So if there's something wrong with your kidneys, right, remember, it's your kidneys that is able to produce the hormone, that protein erythropoietin, EPO. So if something's wrong with your kidneys, you won't be able to produce EPO, right? So you have an insufficient EPO secretion, which you won't be able to make a lot of red blood cells, which will lead to a decrease in your oxygen carrying capacity. So when we look at acute kidney injury, number one, the best intervention for acute kidney injury, right, is prevention, right? Got to remember that, is prevention, okay? Chapter 29 looked at some disorders of the lower and urinary tract, like UTIs and things like that. So we would have talked about UTIs, and so most common you'll find UTIs in sexually active women. They're going to have like a shorter urethra, things like that. So we also want to understand, when we're looking at these lower urinary tract infections and disorders, there's a variety of diagnostic tests that we use to diagnose these disorders, but the most common, right, is going to be ultrasonography, right? That ultrasonography is going to give us an excellent visualization of the urinary tract, okay? Now, also, you got to remember the different types of incontinence, right? And then again, incontinence is just involuntary urine loss, right? You're just, in a sense, like urinating and you don't even know. So these are the different types. So remember urge or urgency incontinence, right? That's going to be the involuntary leakage of urine along with immediately after the sudden sensation of needing to urinate. So this is that urgency. So urgency incontinence is most often going to be due to an overactive detrusor muscle, right, of the bladder, okay, that will suddenly contract. Okay, so you got to remember that about urgency incontinence, the overactive detrusor muscle. Okay, and some treatment for that would be pelvic floor training. Now, stress incontinence, the primary cause of stress incontinence is a weakened or weak pelvic muscles. Okay, so if we lose or if we have some weak pelvic muscles, that will lead to stress incontinence. Okay. Overflow incontinence is where we have urinary retention with consistent or intermittent dribbling of urine. Okay. So remember these types of incontinence. So, when we look at the bladder, right, so you can see the ureters coming to lead to that bladder at that trigone area. So, this is going to be that detrusor muscle right here that we were talking about. So that's the muscle of the bladder that it's that detrusor muscle that is like overactive and it suddenly contracts, and that's giving you that urgency incontinence. Now, normally, right, it's the parasympathetic system, right, the parasympathetic nervous system that will control the bladder and cause it to contract so you can then urinate, right? So this is a learned reflex over time. When we look at disorders such as the neurogenic bladder, right, so neurogenic bladder will refer to us having neurologic lesions that cause the bladder to be dysfunctional, okay? That could be due to like central nervous system disorders or disorders that are affecting the autonomic innervation of the bladder, or neuropathies of diabetes mellitus as well, okay? But remember, parasympathetic control of the bladder will cause it to contract, and neurogenic bladder is where we have neurologic lesions that cause the bladder to be dysfunctional. Some congenital disorders, we have uterococcal right? And this is where you have a congenital cystic dilation or that outpoaching um, of the distal end of the ureters. Okay, so it's really like a dilation or outpoaching of that last part of the ureter. Okay. So when we look at some neoplasms, some like bladder cancer, so the greatest risk, right? Talk about it a lot, unfortunately, but the greatest risk factor is going to be smoking. It's going to be smoking, right? So if I ask, well, what is the greatest risk for, bladder cancer? Smoking, right? And what are some initial symptoms that we see with this, right? Painless hematuria, right? Painless hematuria, okay? When we look at further inflammation and infection, right? Specifically inflammation of the bladder lining, the cystitis, right? This is where we're going to have nitrites in the urine. Okay, so you got to remember that about cystitis. So you're going to have nitrites in the urine along with leukocytes or esterase. These are going to be indicative of cystitis, right? Inflammation of that bladder lining. Okay, so you got to remember that. And let's finish off with some alterations of the reproductive function. So we'll start off with male. And so one of the congenital anomalies that we looked at was micropenis. And so this is where you have a small, normally formed penis with a stretched length more than, 2 standard deviations below the means, right? So it's smaller than average, essentially. And really it's, when we look at the normal growth testosterone, it's going to be dependent. We must evaluate for some endocrine abnormalities that could possibly cause this type of disorder. Okay, if there's some endocrine abnormalities, probably won't have normal production of certain hormones such as testosterone, for example. Okay, but again, we want to evaluate for some endocrine abnormalities with this disorder. So we also have some other congenital anomalies such as hypospadias. Right? So hypospadias is where you have the urethral meatus is going to be located on the ventral undersurface of the penis, right? And then you have epispadias, okay? And that's going to be where the urethral opening is going to be on the dorsal end of the penis, and that's going to point to the proximal of the glands, okay? So you got to remember that about epispadias. Again, that urethra opening on the dorsal end, okay? You also have some other acquired disorders, right? And I'll just talk about phimosis right here. And this is where that uncircumcised foreskin cannot be contracted over the glands of the penis, okay? Usually going to be due to inflammation or infection, generally from poor hygiene, okay? Erectile dysfunction, right? Simply just the inability to achieve or maintain an erection sufficiently for satisfactory sexual performance. And so when we're thinking about an erection, right, we have to think about our parasympathetic nervous system, but that erection is going to require the release of nitrous oxide, right, into that corpus cavernosum, right, that will allow blood to stay in that spongiform tissue. Okay, so we have to remember that physiology of an erection. Okay. When we look at cryptocorchidism, this is also denoted as hidden testes. And so this is where testes that will occupy an extrascrotal position. So they're not in that scrotal region, right? They're somewhere else, basically. And so what we have to understand about cryptocorchidism is that it's the risk factor. It's going to be a risk factor for testicular cancer. Okay? It is going to be a risk factor for testicular cancer. And so testicular torsion, as you can see right here, is the twisting of that spermatic cord, right? And of course, this is going to present with sudden onset of severe testicular pain. Okay, so when we think of sudden onset of severe testicular pain, we can think of that testicular torsion, that twisting of that spermatic cord. Finishing off with alterations in the female genital and reproductive functions, amenorrhea. This is going to be the absence or the suppression of menstruation in the female aged 16 years or older. This also can occur if women, miss 3 or more consecutive periods. So you got to remember that. Okay. Uterine prolapse, This is where we have the sinking of the uterus from its normal position, right? And what's going to cause this is going to be relaxation of those cardinal ligaments, right? So that uterine prolapse is going to be caused by the relaxation of those cardinal ligaments, right? And so the treatment, right, we can implant a small supportive device to hold the uterus in place, okay? So they would place these pessary small devices in place to hold that uterus there, okay? Of course, we have, pelvic inflammatory disease, acute, subacute, recurrent, or chronic infection, right, of these oviducts and the ovaries. We also have vulvovaginitis, okay? And this is going to be an inflammation of the vulva, right? So vulvitis and the vagina, vaginitis. And so what you have to remember is most of these cases are going to be caused by inflammation of Candida albicans, okay? Most cases are going to be caused by Candida albicans. Excuse me. So what is the most common uterine growths, right? So you got to remember the most common uterine growths are going to be these uterine leiomyomas, okay? And when we look at endometriosis, this is going to be the presence of endometrial tissue outside of the lining of the uterus. So it's going to be like ectopic tissue of the endometrium, okay? Hyperemesis gravidarum, and this is going to be characterized by excessive vomiting in pregnant women. Okay, it's going to be characterized by excessive vomiting in pregnant women. And so, what would be the therapy? IV treatment, right, or IV therapy. Okay, IV therapy. Okay. And then, last but not least, some malignant disorders of the breast, right? So cancer of the breast, right? So these breast carcinomas will remain, most common form of cancer in women between the ages of 25 and 75 is the leading, I should say the second leading cause of cancer mortality in women, less common in men. And some risk factors. So what are the risk factors for breast cancer? Well, it would be early onset of mincing and a late first pregnancy. Okay, so you got to remember these, all of these diseases, and I know there's a lot, but just remember as much as you can. Okay, happy studies.